Good evening. I'm Dr. Gian Hart, co-president of the Zumbro Valley Medical Society. It is my honor and pleasure to introduce our keynote speaker, my colleague and friend, Dr. Gerald E. Harmon. Dr. Harmon is a retired Major General from the U.S. Air Force and dedicated family medicine specialist for more than 30 years in Coastal Carolina. Dr. Harmon is currently the president-elect of the American Medical Association. Dr. Harmon has been a valued member of the American Medical Association's Board of Trustees since 2013 and served as board chair in 2018. His distinguished record of service in his home state of South Carolina includes board chair and president of the South Carolina Medical Association. He is also a professor at 2 of the South Carolina's medical schools and is a member of the clinical faculty for the Tidelands Health Family Medicine Residency Program, where he regularly instructs physicians in training. Dr. Harmon is an advisor of the Board of Trustees for his local community health system and is vice president in a multi-specialty physician practice. He has been recognized with the Lifetime Achievement Award from his county's Chamber of Commerce and has served as South Carolina Secretary for the State Aeronautics Commission. Dr. Harmon ended his decorated 35-year career in the U.S. Air Force with the rank of Major General, serving the nation in the Air Force Reserve on active duty and in the Air National Guard, holding responsibilities as Chief Physician for National Guard Bureau. His honors include Distinguished Service Medal and Legend of Merit and the Humanitarian Service Medal. It is my great honor to introduce AMA's President-elect, Dr. Gerald Harmon.
Thank you. It's a real privilege to be here tonight with you early evening. I want to acknowledge the great work and leadership of Dr. Patel and Dr. Hart. They have just been exemplary as leaders of your organization, indeed of the entire profession of medicine. We've all been challenged in this moment of unprecedented public health crisis, the biggest public health crisis our nation's faced in 100 years. And folks like Dr. Patel and Dr. Hart have just taken an incredible leadership role, as everyone in this virtual meeting tonight has taken. And you're all to be congratulated, thanked, and recognized for the many sacrifices I know all of us have participated in, and we continue to do it. We've done this for almost 10 months now. We have another couple of months ahead before we have the vaccine, and I hope the pandemic in our rearview mirror. We have unprecedented time. This is times when all the medical professions, the nurses, the pharmacists, the technologists, the laboratory techs, everybody has just pulled together. I know in my local communities, I'm sure it's there in your local community, it's been an all hands on deck moment. Hope, however, is on the horizon. We've got a couple of vaccines that are out, being distributed now, and we anticipate another one being approved very shortly and adding to the resources. Tonight, I'm going to talk on 3 areas. I'm going to talk about AMA efforts to support physicians during this pandemic. I'm going to talk about the vaccine development and its distribution, and then I'm going to talk about AMA's work to promote health equity during this difficult time. I'll give you a little briefing here. My personal path in medicine, Tion was kind enough to offer that I do have a military career for about 35 years, but it's allowed me, because I was active duty initially, then reserves and National Guard in the latter 25 years, I was able to be a civilian physician for the majority of that. So I've been able to practice family medicine here in coastal rural South Carolina for going into my 4th decade now. It's been a real honor to be a member of this community. I did a residency in family medicine at Eglin Air Force Base. Early in my career, when I started my family medicine practice here in the early 1980s, I had the opportunity to join State Medical Association, and it was new for me. I was new as a doctor, and I don't remember being much of a membership kind of person when I was in medical school, but I got the opportunity to become a member of the State Medical Association. We had in the early 80s this thing called the Young Physicians section that we were trying to organize at the AMA and the local State Medical Association levels. And at that time, I qualified as a young physician, so I joined, eventually became the state chair of the Young Physicians section, became a YPS delegate to the AMA, became really enamored with the opportunity to have a broad reach beyond that of my local community and reaching hundreds and even thousands of patients. I saw that you could have a voice at the national level and also share ideas, share resources, and get a better perspective on healthcare, not only from my community of patients, but the entire nation and this community of patients. So I encourage any young person in this group tonight to think about that career in organized medicine, because you can only touch so many people with one stethoscope. But if you get a role in organized medicine, leadership opportunities, you can touch thousands across your state, hundreds of thousands or millions in your state, and hundreds of millions across the nation with your opportunities for engagement with organized medicine. Really a daunting challenge. I want to tell you what I am doing now in my local practice. You heard that I'm have been here for 30 or 40 years, I'm still pretty actively practicing. I go to the hospital. I still see inpatients. I do a hospitalist shift about 3 or 4 times a month. I've got a hospitalist shift tomorrow morning. I'll have one over the weekend, or I'll have one Saturday morning. Then I'll work in a family medicine clinic a day or so a week. I do precept actively. In a small town hospital, we have a hospital system that's about 200 beds here, scattered in 2 hospitals 20 minutes apart, 20 miles apart, about 100-bed hospital each. So we don't have a real depth and breadth of specialization. So I not only work as a family medicine doc, as a hospital doc, we have 2 intensivists, so I wind up taking care of patients in the ICU. We don't have an occupational medicine system, so I wind up being the director of occupational medicine, the consultant for employee health. I wind up here locally running the infusion clinic for the monoclonal antibodies. I'm sure you're familiar with that as a treatment for early onset COVID-positive patients, particularly those with high risk. So we have a bamlanivimab infusion center set up. I ought to get extra credit for pronouncing that without stumbling on it too. And also, no surprise, since I'm employee health and occupational health, I'm in charge of the vaccine distribution program here. So a lot of things in a small town I can relate to as a small town subject matter expert, at least tell you operationally what we're trying to do and logistically how challenging it is. And we'll get into that later on. But just to give you a perspective that I'm pretty busy right now. And I understand how much you're all weighing and busy too. So I think I can be empathetic with many questions and concerns you might bring to the table. And then I also see my young residents and fellows being incredibly engaged and energized as they step up to the needs of the pandemic response force. The pandemic response from the AMA has been impressive, and I'm real proud of it. One of the things we're trying to do at the AMA is make sure we provide up-to-date, evidence-based resources. We want to be the one true source of reliable facts that we can spread to the community, spread to our patients, spread to our providers. And then we also want to help physicians and practices recover from the disruption that they've had and the damage economically, personally, professionally, relationship-wise with the pandemic. We want to make sure patients don't have obstacles to restore normalcy, to get access to care, not only for the COVID-related illnesses, but the pre-existing illnesses and the chronic medical conditions that still need ongoing care. And finally, we want to make sure we advocate at the federal, state, and policy development level and regulatory level for science-based, equitable policy. Almost a moonshot, but I think the AMA is more than capable of taking it. One of the things I found particularly as practicing doctor of really of value to me is the AMA's JAMA Network COVID Resource Center. I really check it every day. It gives me up-to-date evidence. It gives me some scientific peer-reviewed journal articles. It tells me in a lot of conversations what's going on. You'll find that it's been incredibly valuable for most practicing physicians, and I wind up sharing it with my medical colleagues almost every day. So it's really good. There's educational videos across the entire spectrum of the COVID disease epidemic and the response and the vaccine development. So it really is good. It also helps me in office management that it tells me about, gives me CPT coding guidance. It allows me to tell my colleagues and my office managers what codes to use for whether we're testing with a PCR-based or antigen-based swab. It also gives me an idea how to order the test and then how to order the therapy and allow us to get credit and or compensation for it. So it's very valuable. One of the things we've been having to fight with, and you can understand the struggle, is we're facing a two-front battle. First off, we have all the issues of taking care of severely ill patients, and yet at the same time, we're having vaccine hesitancy, treatment hesitancy, and we're getting lack of response from many of our regulators and governors and standards not listening to what we think the science tells them about social distancing, wearing masks, washing your hands. And so we're trying to fight a war of misinformation and disinformation and inaccurate information that's probably based more on social media than on peer-reviewed evidence. Recently, our AMA President Sue Bailey has done a real good job at going on the various earned media, not social media, but earned media sites, and was advocating for the scientific solutions and the evidence-based guidelines that we should all follow and should propagate throughout our physician membership and our patient membership. And we've also, one of the things I mentioned, this is an all hands on deck moment. We've had our Mask Up campaign. Even as AMA is urging the public to take responsibility, we're seeing that there is some responsiveness where our doctors are trying to get that message out too. Thank goodness, I just got last week my second vaccine. So I am hoping I'll be resistant and immune to the disease. But I'm still, anytime I go out in public, my wife and I go out in public, which is limited because we're not going out recreationally. But if we do go out, I'm wearing a mask. I have a hand sanitizer with me. I keep my social distances. I stand respectfully in line. I answer questions. They do recognize me. I'm a small town community. But I'm not going to be seen in public without wearing that mask, without practicing all the things I'm asking my patients and my community, my leaders to practice. And the wear a mask, the 3 W's, wear a mask, watch your distance, and wash your hands. It's really pretty easy to do. And with that compliance, incredibly mitigation and transmission of this virus. Very, very important. What the AMA has been doing at the national level, and y'all have seen it too, is we're advocating for personal protective equipment for physicians across the nation. We've partnered with Project N95 to make PPE available to AMA members. We've called for the Defense Production Act to provide frontline PPE to our frontline workers. And we developed codes and all so that we can get compensated and reimbursed eventually for the extra expenses all of us have had to order. I've had to order more supplies for my practice than usual. You know, if you take care of active COVID patients, it takes 3 times as long. You have to get data from them, to interview them, to examine them, and to communicate with their families afterwards. You have to go in and out of the rooms with changing your gloves and your protective equipment very frequently. So it's incredibly time sensitive and resource intense to do all of this. And we're trying to make sure that we can afford to recover from it when we get back to a sense of normalcy. One of the things we've also done good at the AMA, and I think I'm real proud of this too, is we've been encouraging the government, and they have been very good. CMS and other payers have been very good about extending telehealth codes so that we can take care of our patients and they can access us without having to come into the offices and leave their homes. We get compensated appropriately for it. We've been able to have some site of service regulations reduced and relaxed. We can do telehealth with compensation, and we can do it reliably. And that's really going to be a sustainable moment after the COVID pandemic passes. So the AMA is trying to make sure that it's not just a once in a year opportunity. It's going to be a sustainable method of practice, we think, for many of us, as long as we're appropriately recognized for the care and the care is held accountable. The type and quality is held accountable by quality organizations such as boards of medical examiners and state specialty societies and state regulatory societies. It's important that we have some structure to this, and that's really in good shape. We've had some new CPT codes introduced so we can allow our practices to appropriately bill and get compensated for it too. All in all, I've been pretty proud of what we're going with in the AMA with regard to this. Let me tell you about the vaccination, the new phase that we're dealing with right now. People have asked me and asked others, I think, why are we having such a rapid turnaround and a rapid development and development of the vaccines? And it has bred to some degree a little bit of distrust about not healthcare providers, but certainly around the patients, that this new vaccine production has been so rapid and quick and faster than ever before. Has it been done because we might have skipped some safety steps or something? And the answer is really not. Typically what happens, and this slide we'll talk a little bit about it, you see is you have an exploratory phase, a preclinical stage, an investigative new drug, IND application. That can take up to 2 years just to kind of get ready to produce the vaccine. Then you can have a trial process where you have phase 1, 2, and 3 trials. 1 is a very small cohort of patients. 2 is a larger cohort of maybe 30 to 50 with you have a treatment. And then the phase 3 trials, which predate just before being approved, as many as 30 or 40,000 folks with a cohort of patients in a placebo group. None of these trials have been shortcutted in the scientific method. What has been shortcutted is the bureaucracy and the funding for all of these things, where it might take a year or two for the CDC or the grant funders, the NIH and folks like that, to provide $decimal million or multi-million dollar contracts for the vaccine developers. That's been pre-funded. So as soon as the science was done, as soon as the actual phases were complete, the evidence was released to the various review organizations at the FDA and the CDC and NIH, and they just said, yep, the science is strong. We don't have to wait months to years on reallocation of resources. Because we're in an emergency pandemic, let's move forward to the next scientific phase without stumbling over a bureaucracy or financial hurdle. And it really worked out incredibly well. You know, this is Operation Warp Speed, which is a little bit, it sounds a little Star Wars or Star Trek-y. It made it sound almost gimmicky to some of us, I think, but it really wasn't Warp Speed. It's incredibly fast. In May, it was announced. In November, we had some results already in hand, phase 3 trials. Pfizer and Moderna vaccines have received emergency use authorization. The CDC Advisory Committee, ACIP, has recommended that health workers and nursing home residents be in the 1A recipients. In December 2020, we started immunizing folks. I received mine about the 13th of December, the first dose, and we were off and running literally. So it's been incredibly fast. There has been some misinformation, some hesitancy. We know at the AMA, and we've been consistent at asking the vaccine development trials, the FDA and the CDC, to make sure we have a broad registry of applicants so that we could screen appropriately and see the results of these vaccines across all recipients, representing all genders, ethnicities, races, and get an idea of the safety for the projected patient population. You know, historically, we've had vaccine misinformation. At our House of Delegates meeting, we've known the recent House of Delegates meeting we had in November. We adopted policy to combat misinformation through public education. We're interested in forming a coalition of healthcare organizations, promote the facts, and encourage acceptance about COVID-19 vaccines. And we're going to continue to monitor the data to make sure that it is safe, and we'll update anything that is new and groundbreaking. We believe in transparency. We believe in taking care of our patient population and being a real trusted source for vaccine information and not misinformation. As far as vaccine hesitancy, and we've seen that as many as 60% of Americans, over half of them, have been hesitant to step up and get the COVID-19 vaccine. And 1 out of 5 have just said, I'm not going to get this vaccine. I'll tell you, in my patient population, I'm in rural South Carolina, probably 40% of my patients are African American. And I tell you what we know from studies, they'll look to their trusted leaders in their community. My patients will. I have earned that respect after almost 40 years here. They'll trust me. And in most communities and many communities of color, that's not going to be true. And across the country, only 14% of African Americans and 34% of Latinos are saying they absolutely have trust in it. The other ones have some hesitancy, not denial, just hesitancy, because they've had historically perhaps some non-equitable distribution of information about it, and maybe even felt that they weren't fairly treated when they were in vaccine trials. So we have to overcome that hesitancy. We have to change that going forward. One of the messages that we want to make sure, the best message, and we know this for sure, is that the best message for vaccine administration, efficacy, and safety are influencers within the communities. Sometimes that's a personal physician. I'll tell you that in my community, it's the leadership, the community leaders. I've got folks that I can reach out that I participate with, including most in the faith-based communities, churches, community organizations, community health centers. They have trusted leaders in those communities that I reach out to and that reach out to me for up-to-date vaccine information. And that's what I think is going to be the answer for reducing the vaccine hesitancy. One of the things we've done, we've had vaccine webinars at the AMA. We have tried to have one of those every week. I participated in several. Sue Bailey has, our current president, our immediate past president, Patrice Harris, has done that as well. Those webinars are available on the AMA website. They're about 15 minutes long, maybe 12 minutes. They're little snippets of information where we're giving our opinions and our personal experiences to the communities, and they're extremely well received across America. We're going to talk about the incoming administration. We've made some recommendations to them. We're going to urge the incoming administration to implement a national strategy, more than they have now, to provide states and communities with better guidance regarding rapid distribution and administration of vaccines. I'll tell you what's going on in my community. We are a small community hospital. We have been able to establish that we're a vaccine distribution center with our state Department of Health and Environmental Control. We've immunized 1,600 healthcare workers, frontline workers, including myself, laboratory techs, nurses, critical imaging technicians, x-ray technicians, blood bankers, things like that. We've reached out to the school nurses, the home health nurses, the cancer hospice nurses, the nursing homes with the 1B vaccinations. So we've got a lot done. Now we're opening up to those 70 and older in the 1B population. We have had 20,000 registrations in the last 24 hours, volunteers to receive this vaccine, 20,000. Our community only has 40,000 in the entire county. So half of our county is sticking their hands up, and probably surrounding counties too, because they're not all 70-year-old. But we've had 70-year-olds from surrounding counties know that we have the vaccine, planning to distribute it, and it's been an incredible demand. So it'd be really nice if we could be reassured by the federal government and the vaccine distribution centers beyond our stages that we're going to be able to get that vaccine in hand, because we have plans to store and distribute it. We just need to make sure we're going to get a supply of it. We're going to offer out, and we've had good correspondence with the incoming administration. I think we're going to be received well. We're a trusted source to them, and that's a very good positive sign for those of us in the AMA. Health equity. In 2018, when I was board chair of the AMA, it was my privilege to be able to establish a health equity task force. We had a good response. I picked about 11 folks that I had trust in that had expressed an interest in health equity within the AMA, and that health equity task force came up with many recommendations that might help us at the AMA. And then in 2019, we established at the AMA the Center for Health Equity. And it's now gotten traction. It's well respected now. We're promoting equity in healthcare, advocate for healthcare access and research. In the last year, in 2020, we raised awareness about health impact of police brutality, COVID-19 unequal impact, and we launched Prioritizing Equity online video service. We've helped launch a national Release the Pressure campaign to improve heart health of Black women. We've done is made a substantial investment and an advancement in promoting health equity. We have a lot of work ahead of us, but we're not going to drop the ball. I think it's a sustainable path that we can keep on. I'll tell you, in my community and in your community, you know that the response to COVID infection causes increased complications of COVID in people of color, African American, Hispanic American, and Native Americans by 2.5 to 2.8 times more than white Americans. And that's how sick they can become. They're disproportionately impacted. And the death rate from COVID in the people of color community is twice what it is in the white community. With all other factors being standardized, That's unacceptable. We just have to do better, and we will do better. I'll tell you, in my community, we're going to vaccinate in areas that are underserved. We're going to vaccinate in an old high school auditorium 2 days from now, and it's located in the center of a community of color, and that's where we're going to start our first vaccinations in my small town. And we've already had a great sign-up rate. The nurses are good about volunteering to be there. I've developed a plan to handle complications if there are any. There are not that many, but I've been on TV and radio commercials here in the town. I've been out to my preachers, talking to them, my colleagues, and so we're looking for a good vaccination effort there. One of the other issues I've found in my community, in our state, is when we treat our patients that are ill, acutely ill, in the first 10 days of onset with bamlanivimab, the monoclonal antibody, disproportionately, we have not been able to get to our folks of color. And I think it's because our doctors in that area don't have the same access to the bandwidth to fax in, to call in, to get on the website and recommend their patients that are sick with it. So we've made every effort to establish and reach out to our federally qualified health centers. My partners in these areas have a direct hotline to me to get their patients in if they're qualified, so that we get every opportunity for health equity and for equitable delivery of this, I think, life-saving monoclonal antibody treatment. But you have to be focused on it. You have to set your system to do that and not just trust that the patients will come to you. You have to have a proactive stance of doing that, and I'm real proud of our community and the AMA for supporting that type of stuff. The AMA, as far as health equity and addressing the issue of racism and brutality, we as an AMA board made this statement in June 2020. It talks about, as you can see, that racism is an urgent threat to public health, the advancement of health equity, and a barrier to excellence in the delivery of medical care. And we oppose all forms of racism. We denounce police brutality and all forms of racially motivated violence. We're actively working to dismantle racist and discriminatory policies and practices across all of healthcare. And I don't need to tell many of you in the audience, a lot of these are subtle, unintended consequences of policy. I used as an example our equitable and potentially unequitable distribution of the monoclonal antibody. We work really hard to get this monoclonal antibody distribution system in our community, and it's so new, we had to set up an entirely different infusion center. You think about it, you've got infected COVID patients. We tell them, don't go outside your home, and then we say, hey, we've got this treatment, but we can't bring you to your home, so you have to come to the infusion center. And our infusion centers are typically where we take our most vulnerable patients that are getting immunotherapy, they're getting cancer chemotherapy. So we had to establish an entirely different infusion center with a different team of infusion support personnel, nurses and things, and yet have it nearby so that the resources were available for both areas. It took some logistical challenges, but we did manage to bring people in, and that just inherently might have been, without realizing, a bit unequitable, because some of our folks have been told for years now, if you go there, you're going there because you have cancer or something, or you have a problem, so they don't necessarily trust going to where the infusion center is. So I had to go out to the communities, and we made sure we made a good proactive effort to understand that folks that were sick with COVID could still be safe if they came in and they were safe in our care. We had a Safe in Our Care campaign. All of these unintended consequences of just not thinking outside the box. So we're doing that at the AMA. I'm real proud of what we're doing, and I'm getting educated every day on better ways to do this. We understand that violence, physical or verbal, among law enforcement officers and the public, particularly among Black or brown communities, is a critical determinant of health. Early in my career as a reserve police deputy, so a sheriff's deputy. So I think we do a real good job in our community with a substantial member of our deputy force being persons of color. And I understand that unintendedly you could have some extra problems with it. I have two partners, an African-American female and an African-American male, and we've been together about 10 years now. My senior partner, who's been with a little bit longer, is Dr. Mann, and Dr. Mann has 5 children, 3 males and 2 females, and he's now one is in college, 2 are in high school. And Casey and I talked about the police violence some years ago and the problems with persons of color, even in small communities like ours. And Casey came to me and said, Jerry, I had to have that talk with Matthew, my oldest one. And I said, you mean the talk? He said, yeah, I had to tell him that he can't drive around with the same confidence that he might think he would be. And he had to have the man-to-man talk. And he told Matthew, he said, Matthew, if you get stopped for a traffic stop or something, you have to change a little bit of your attitude, because he's a teenager. He was full of what I call spit and vinegar. And Casey had to have that talk. It was a difficult talk for him, but he and I knew exactly what kind of talk he was having to have. It's a challenging talk. That shouldn't be the case. That should not be the case. And Casey and I know that. Kim Drayton, my other partner, we know that too. But the reality is, it is a talk that has to be held. That's going to have to change. And AMA is going to be one of the champions for changing that talk and the need for that talk. We still are working to support the ACA. Even with all its impurities, it is still a great effort. We have 20 million Americans who've got coverage for health care. With passage of the ACA, we want to improve it, not revoke it. We can do that. We're still being active in the federal and advocacy level to do all of that. I could go on and on about all this stuff, but I'm going to tell you, I want you to know how proud I am that what the AMA is doing is something I firmly believe in. I think it's things all of us can look forward to as a good legacy to have. If we look at this time, the difficulties we've been through in the last year in our nation, nation, our communities, indeed in the world. I think this is a change for transformational change, not only with handling coronavirus, but addressing the issues of health equity, access to care, improved quality, and even access to care in other ways, such as telehealth, digital health. We've changed medical education. We know that we can educate physicians sometimes through distance learning. We've had just an incredible, successful run. I know we're all challenged. I know we're a little bit tired. I have not COVID fatigue, but I have COVID response fatigue. I am tired of having to maintain social distances. I have a 90-year-old mom in assisted living. I haven't been able to give her that non-virtual hug, the real hug in 10 months. We telecall, we do video conferencing. I go and visit her and we knock on a plastic window and I say, "Hey, Mom, how are you?" And she's learned the virtual hug. It's challenging. So I want you all to know again how proud I am to be able to talk to this organization, how proud I am of every physician in this organization, and how much your work means to our American patients and how much it means to the success of the Society of Medicine and the Federation in our community.